discuss direct primary care model and how communities can put it to use as they work together to make sure everyone in every neighborhood and community has primary care. Sarah, please go ahead.
Thank you, Michael. So I'm here to talk to you about a little movement that is revolutionizing primary care in the United States. Do I have any fellow DPC clinicians in the crowd?
Sure.
One. Is there anybody in the audience who has a personal DPC PCP? 2, 3. Good. All right. This talk is for the rest of you.
I heart DPC.
Okay. So I've been practicing in the DPC model since 2017, and that there's not a big enough check you could write me to make me go back and practice in the insurance setting. Am I right? I want to start by telling you a little story. My hobby, I guess, is that I volunteer regularly in a little free clinic in my community. It's an all volunteer-run clinic. And our patients are mostly living in the deepest poverty that one can be in the United States. Many of them are unhoused. And a few days ago, I had a new patient, we'll call her Betty. I won't describe her in too much detail to protect her privacy. But Betty is a 78-year-old woman, frail, living on the streets. Just imagine. And she has not a tooth in her mouth. She has some kind of neurologic condition and some psychiatric overlay. The three of those things put together make her speech almost completely unintelligible. Like I barely understand a word that comes out of her mouth. Someone had recently put her on a diuretic to treat her chronic or extremity swelling, which then caused her to have urinary incontinence, which she absolutely could not manage on the street. And 3 days before she saw me, she had been to the emergency room for chest pain, which I only knew about because she brought me the discharge paperwork. There's no way she could have told me that story. And they didn't find anything to explain her chest pain, but what they did find was a mass in her lung that was highly suspicious for malignancy. And they told her that she needed to follow up as an outpatient to get a CT scan. And the discharge paperwork said, follow up with your PCP. And the very next line said, you have been referred to no PCP or family physician. And so she came to us. She's obviously Medicare age. She's covered by Medicare, but she had lost her Medicaid card when everything she owns had been stolen, which is very common for people who are living on the street. And, our little clinic doesn't have a lot of resources. We certainly don't have a CT scanner. But we put compression wraps on her legs, we gave her adult diapers, a few little medicines, and we connected her with a community health worker, which you heard a lot about from Cheryl. These are the heroes in our community that are doing incredible work. And that community health worker then is going to start getting her plugged into social services, is going to file an adult protective services report and get her hopefully moving in the right direction. This talk is dedicated to Betty. We're going to talk about why primary care is broken in the United States and what insurance has to do with that. We're going to talk about what DPC is and how DPC can remove barriers to access to primary care and how you can use direct primary care as a tool to organize in your community and solve primary care problems. I am employed by Elation Health and a primary care focused EHR company. I promise it's not like the others. But I don't consider this a conflict of interest. We actually are more than a primary care company, primary care EHR company. We're a primary care company, and so it's more an alignment of interest, I would say. Senator Friedman's words are ringing in my ear that we need to stop examining the problem. So I don't want to spend too much time on this slide. We spend way too much money on healthcare, yada yada. Not enough Americans have insurance that actually pays for routine primary care, yada yada. And the insurance company is wasting a whole lot of that healthcare money. And then, of course, more data about how we perform so poorly against peer nations in terms of outcomes and costs, longevity, and Americans often delay care because they can't afford it. And the difference between us and those better performing countries is that they have a strong foundation of primary care. And in fact, you may have seen this study out of Oregon that showed that for every $1 spent in primary care, $13 are saved downstream. That's an enormous ROI. Can't be spending more money on primary care. This slide alone I could spend the whole 30 minutes on, but I won't do that because we have more important things to talk about. But what I want you to take away from this is that in any other industry, we use insurance for catastrophic events. A car accident, your house burns down. We don't use it for the routine things like getting your car serviced or putting a new coat of paint on your house. But in healthcare, we use it to pay for those routine, regular services that everyone needs. Guess what primary care is? It's that healthcare service that everyone needs. And it turns out that using health insurance to pay for those routine services that everyone needs actually drives up the cost of healthcare. And it does that in a variety of ways. The first way is that it removes price transparency. So consumers don't know how much anything does cost or should cost. They can't comparison shop. And that removes the supply and demand market forces on healthcare pricing in general. The second thing is that it adds this enormous administrative tax to the process of healthcare delivery. And in fact, for every dollar that we spend on healthcare, 34 cents goes to the insurance company, the insurance industry. And for every 1 hour that a physician spends in direct patient care, they can spend another 2 hours on paperwork. So this is a huge burden that we are just like a refrigerator hauling uphill on our backs all the time in the healthcare industry. And what that has resulted in is this paradigm where we have a system that's built for sick care and not to keep the public well. It's an industry designed to keep primary care anemic and weak, which then makes sure that we're spending a lot of money on those downstream expensive services that we hope we never need. That then drives more profit, mostly for big corporate insurance giants that are both predator and, dare I say it, parasite. And what they're doing is they don't contribute anything of value to the public health, but they extract wealth from our communities. And this is unsustainable. Betty's the end point of that system. So what is DPC? First of all, it's a different way of paying for care. It's primary care outside of the insurance machinery. What it is paying directly to the primary care clinician a flat fee, a subscription fee, a membership fee, whatever you want to call it, just like you pay for a gym membership, just like you pay for Netflix, right? And in exchange, you get unlimited access. The flat fee covers all the usual care that you would receive in primary care, completely transparent, no surprises in the pricing. It turns out that this is actually a better business model because instead of primary care physicians having to chase volume just to keep the lights on, They actually can make as much money, sometimes even a little bit more money, and manage fewer patients. So the patient panels go from in the thousands to 600, sometimes even less, just depending on how complex your patient panel is, and other factors influencing. But the bottom line here is that we often talk about primary care as a relationship, and it is, but it's also a promise. It's a promise that I'm making to my patients that I'm going to be there for them. And I cannot keep that promise to 2,000 people and do a good job. I just can't do it. In DPC, I spend way more time with my patients, and we're able to turn over the rocks and find out what really is impacting their health and really start working on those things. What's really cool about this is that there are no insurance rules that are determining arbitrarily where and how care can happen. So I can see a patient in my office, I can see a patient virtually, I can meet you in a Walmart parking lot, I can go to your home and visit you. We can do care anywhere, and we do. We can go on a walk while we have a visit. I can meet you for lunch. We can do all those things if we want to. I don't haggle with middlemen to get paid. And a common critique of DPC is that it creates inequity because it's only for the well-off who can afford it. And we're going to talk more about that in a minute. But I want to offer a counterpoint to that, that the insurance-based primary care model also creates inequities. In DPC, if you have insurance or you don't have insurance, if you're underinsured, overinsured, doesn't matter. I still see you. It helps if you have insurance because then I can get you downstream services more easily, but it doesn't impact my care for you or your access to me. So this is a movement that started small, but it has been growing like a fire in dry grass, let me tell you. The policy and the market landscape are shifting a lot to make room for DPC, and it's really starting to take root in our culture, which is so exciting to see. And we did see with HR 1 that the tax code was corrected, so previously DPC and health savings accounts were incompatible, and now you can use your HSA to pay for DPC, which really unlocks barriers to employers making sure that their employees get good primary care. And the more novel thing that many of you may have not heard about is that there are community-owned health plans that are coming up that basically are locally owned, locally governed, locally funded, and they're built on a DPC backbone. So it's primary care first, and we're not taking any money and shoving it off to some corporate insurance conglomerate. The transparent pricing works. The payment is direct to the provider, and there's no, networks or any of that crazy stuff that is wired into how insurance works. And this has actually been proven at scale across community. So more and more of this is cropping up, and it's a great way to solve those problems locally. And these numbers really speak for themselves. This is how much the movement has been growing. Love to see it. Look at that. 837% growth from 2017 to 2025. And interestingly, the demand for this by patients is actually growing faster than clinician supply. So if you are a primary care clinician and you're worried that you might not be able to keep your DPC going because you won't have anybody to come find you, guess what? They're looking for you. And so DPC physicians have, left an environment where, they've been overworked and all this administrative work, and they have been measured to death on what some insurance company defines as value, colonoscopies and mammograms and what have you. And so they are allergic to being measured. And so historically there has not been a lot of data about, locally, the physician and their patients know that they're reducing costs, that they're improving outcomes, but we haven't really done a very good job of measuring that. This is a really neat study. It's on a DPC that is an Elation customer, that's how I know them, called Innovia Health in Green Bay, Wisconsin. And it was started by Dr. Sabina Singh, who's a family physician, and she had spent, I think, 12 years employed by a health system and was fragged to a crisp. And she left and decided that she was going to leave medicine, but eventually found her, this is a common story, she eventually found her way to the DPC model and started up this direct-to-employer model where the employers, most of them manufacturing companies with blue-collar workers, many of them the working poor, and started building this DPC model for those workers in her community by having the employer pay the DPC membership fee. This is an important shift away from the retail model that you may have heard of. And they're not the first to do it, obviously, but this is an important study because it's the first of its kind to look at the experience from a 360-degree angle. So they looked at the experience from the patient's perspective, from the employer's perspective, and also from the PCP's perspective. NPS stands for Net Promoter Score. If you're not familiar with it, it's a score on a scale of 0 to 100 that basically answers the question, would you recommend this to a family member or friend? For context, Apple's NPS score is 58, and they are regularly regarded as one of the highest NPS scores in the tech industry. The Mayo at Rochester is 55. Okay, so these are phenomenal scores, and it's just some small but mighty DPC operation in Green Bay, Wisconsin. What's really important about this to me is that we have a crisis level PCP shortage in this country, and these PCPs are happier working in DPC than they are anywhere else. Look at these vital signs: burnout, job satisfaction, visit length, time spent working in the EHR after hours, patient panel sizes. Every single one of those got dramatically better in this model. It's irrefutable. They also looked at something called the Person-Centered Primary Care Measure, or the PCPCM, which if you haven't seen it before, please look it up because it is so cool. It's a validated measure that looks at things that we know are core to primary care and drive better value, better outcomes: continuity of care, coordination of care, access to care. And in this study, the score goes up to a maximum of 4. And so for quick response, they got a 3.9, ease of access 3.8, trust and referrals 3.7. It doesn't get any better than that. This is data that comes from Premise Health. I don't think anybody would call Premise Health DPC, but it is a direct-to-employer model. It's a massive platform. We more think of DPC as like local in the community, but again, it hasn't been very well measured. And we can use this data from Premise Health to think about what primary care looks like when it is divorced from the insurance machinery, okay, that direct pay model. So the employer is paying Premise Health directly to provide primary care. And look at this, they took 1/3 off of total cost of care. And I don't even think, sorry if there's anybody from Premise in there, but I don't even think Premise has a very good primary care model, to be honest. But because they took insurance out of the equation, and because they were able to really be available, accessible, and coordinate care for their patients, they were able to cut hospitalizations in half. And this is not novel. This is what DPCs are doing all over the country. So what this shows us, this combined with the Innovia data, is that patients are happy, PCPs are happy, employers who sometimes pay for this are happy, and we're actually getting people healthier and well, and decreasing total cost of care. So is DPC affordable? That's a lot of the critique of DPC, that it's not affordable. And this is worth talking about. Michael was talking about at the beginning of the day how an emergency room visit can cost $2,000 up to $10,000. The average DPC retail cost for a patient to pay for DPC in this country is $99 a month. You pay more for your car insurance, and guess what? You're a lot more likely to use primary care than use your car insurance. And when a union pays for it, or when an employer pays for it, sometimes it's like $65 per person per month. So this is less than 1% of our per capita healthcare spending. It's really not a lot of money when you think about it, when you put it in perspective. And actually 80% of DPC patients say that this has decreased their out-of-pocket healthcare expenses. So paying this money up front for that primary care relationship actually saves money, not only across the healthcare system, but also for the patients personally. So this is where the rubber starts to meet the road a little bit. And I think it's important to say that DPC doesn't automatically reach everyone, okay? But it can. If you stop thinking about it as a personal purchasing decision and start thinking of it as a community-owned utility, where it's a shared infrastructure problem that we're solving together in our communities. So purchasing primary care by the month or by the year, through getting together people in the community, stakeholders who care about this, can actually guarantee primary care for everyone in the community and actually cap their financial risk. EMS costs go down, police costs go down, emergency room visits go down. It really is a great way to solve primary care problems. We're using our collective financial power and social influence to provide DPC, to pay for DPC for people who otherwise cannot afford it and can't get access. And I think it's also important to point out that you can advocate at the state level, which is still more local than federal, right? For Medicaid to build DPC wraparound plans, and this is already underway in many states. What that means is that Medicaid would pay that upfront DPC membership fee and then use the claims process for all the downstream care. And Medicaid is broken. It pays for the cost of a visit, but it does not guarantee access. So I think if you think about DPC as an organizing tool, this fits so well with primary care for all Americans. Start by connecting. Call 3 people in your community and put together a local work group. Build a coalition. Reach out to stakeholders in your community who care. Assess your primary care access, the way we heard from Pam and Netta earlier. And another thing they did in New Bedford that I was just hearing about is that they got a city resolution passed declaring primary care as a community priority. And you can find a lot more information about this at primarycareforallamericans.org. So Betty, who I told you about in the beginning of this, has a small group of mighty volunteers and a community health worker standing between her and dying on the street. And that is the community organizing model working. We built a coalition. We are using community-funded resources. We are providing primary care outside of the insurance industry. So this may not sound like DPC, but I would argue that it is a stripped down version of DPC. It's more fragile. We are under-resourced. We are dependent on volunteers. But the difference is that community organized DPC is the institutionalized and sustainable version of this, of exactly what we're doing for Betty. And it shouldn't depend on whether or not volunteers show up. It should be structural, and it should be guaranteed. That's what we're building at Primary Care for All Americans, and that's what this movement is for. Call 3 people this week.